Hi, everyone. Welcome to Brain Talks. I'm Deborah Kan, founder of Being Patient. Today, we're going to talk about hormones and memory loss. Is there a connection? How do we know? Where is research at? Joining me today is Dr. Pauline Maki. She's the chair of the Society for Women's Health Research Alzheimer's Disease Network. She's also a professor of psychiatry and psychology at the University of Illinois at Chicago. Professor Maki, thank you so much for joining us.
Thank you for inviting me.
So let's just start with the very basics, okay? As we enter our 40s, early 50s, and we say, and I'm completely guilty of this, I feel like my memory's getting worse. Is there truth to that?
So this is a really important question for women. It is in fact the case that both men and women begin to experience changes in their memory and other cognitive abilities like attention and concentration as they age. The question that's relevant for women is there an additional effect of what we call reproductive aging or the menopausal transition on cognitive performance? We used to think that the answer was no, but in fact, there are now two large prospective studies that follow the same cohort of women from the time they're premenopausal to postmenopausal. And in fact, those women do experience what appears to be a transient decrease in objective memory performance as they transition through the menopause. So yes, it does appear to be real.
So do we know exactly how hormones are related to our cognition? Why is a fluctuation in hormonal levels impacting what's happening inside the brain to make it impact our cognition?
So that's such an important question. There's two general ways that we think that the hormonal changes of the menopause can influence cognitive performance. One is through the direct effects of estrogen and progesterone on brain systems. So we do know that the hippocampus and the prefrontal cortex, areas of the brain that are rich in estrogen receptors and are key to our success in remembering, that those areas respond differently to fluctuations in estrogen, whether it be following removal of the ovaries, which is done surgically in some women, whether it be across the menstrual cycle. So those brain areas do in fact change in their sensitivity. That's what we would call the direct hormonal effect. So that's one direction. The second one is through menopausal symptoms. So menopausal symptoms can also affect cognitive performance, and the most common one that we hear about is sleep disruption. So sleep disruption is very common in women during the menopausal transition. Sometimes it's related to hot flashes. And we also have some data to suggest that hot flashes may contribute to memory declines in women. So in summary, we have the direct effects of the hormone plus the effects of menopausal symptoms.
So before we talk about what you can do about this, I want to back up a little bit and talk about, I know we women experience different fluctuations in hormones at different times of their life. Pregnancy being another one. I've had 3 children. I know with each pregnancy, I felt like I couldn't remember anything. So is that all related? Is that normal to also, when you're pregnant, suffer memory loss?
Yeah, so it's also normal for women to report memory loss and to actually show memory loss in association with pregnancy. It can be challenging, again, to disentangle what are the direct effects of the hormonal fluctuations, what are the effects of sleep deprivation, which of course is ubiquitous during that time, that experience in life. We also know from very nicely controlled studies that even the hormonal fluctuations across the menstrual cycle are associated with changes in cognitive performance and changes in brain function that we can measure using neuroimaging.
So when you conducted the studies on and followed, the cohort for a long period of time, how did you test them? Take us through what that study looked like, and how were you testing their memories through the course of, before menopause, during menopause, and after?
So the cognitive abilities that appear to be changing during the menopausal transition are cognitive abilities that show a female advantage compared to men. So there are normal sex differences in cognitive abilities. Relatively speaking, men, for example, perform better on tests of visual spatial abilities, an advantage in men that's thought to be driven in part by higher levels of testosterone. And conversely, in women, women show a lifelong advantage in verbal memory. So what do we mean by verbal memory? Very simply, it's tested with word lists. So think about a grocery list. Can you learn the grocery list over successful trials? Can you remember it after a delay? That's a very common way of testing verbal memory. Now, we have a sense that these tests are sensitive to estrogen because women show a decrease in performance on these tests, the verbal memory tests, when their ovaries are removed. And adding back estrogen reverses those deficits. So that's a very strong piece of evidence for this particular verbal memory ability being sensitive. So in general, what we do is we take that evidence, we use those specific wordless learning tests, and we administer them, annually to women as they transition through the menopause.
Around how many women have been tested in this way? I mean, in your study, how many people were tested?
Yeah, so in our study, it was about 750 women. In other work, it's 1,100. In other work, it's 403. So it's a lot of women followed longitudinally.
Okay, and we're starting to get questions in now. The most obvious being, well, what should we do? Should we all be on hormone replacement therapy? And if so, when? I mean, I've spoken to another researcher who said it's really important to go on it before you go through menopause, because what you want to avoid is that steep drop in estrogen. Is that true?
So it's interesting to think about the timing of initiation of hormone therapy. Let me start by saying that hormone therapy is not indicated for cognitive problems, and it's not indicated for the prevention of Alzheimer's disease. So what our discussion is going to be about really is what is the effects of hormone therapy on cognitive function and perhaps even later risk of Alzheimer's disease for women who are using the hormone therapy for the main purpose. And that main purpose is the treatment of hot flashes. And so 80% of women experience hot flashes as they transition through the menopause. For many women, these are very disruptive, moderate to severe, and they also disrupt sleep because women wake up in what's called a night sweat. So when we think about the timing of initiation of hormone therapy, we want to think about the timing of initiation in relation to those specific symptoms.
So if you want to wait for the symptoms to come, or do you want to start hormone replacement therapy when you're approaching that menopausal age? I mean, I guess it's different for everyone, so it's hard to tell.
So the menopausal symptoms actually do begin during the perimenopause. So this is the perimenopause for those who are kind of curious about how we define this stage of life. There's really two phases of the perimenopause. One is the early perimenopause, and this is where women's cycle lengths change. What do we mean by that? So let's say a woman got her period once every 28 days on average. When she's in her 40s, typically, maybe now it's once every 31 days, and then she gets it 17 days later. So that timing in between cycles changes. That's the early perimenopause. And in fact, that's when we can measure these changes in memory performance. So isn't that interesting? Women might not even know that they're in the perimenopause, and yet the cognitive abilities are in fact shifting during that time. Now, when women get into the late perimenopause, that's when they skip a period. They go 60 days without a period. And during that phase is when we see the largest changes in memory performance. The very good news for women is that memory performance bounces back, it appears, in the postmenopause. So to your point, if in fact the memory changes are occurring during this perimenopausal transition, then the window of opportunity for women is in fact during that perimenopause and not as much later.
So does that mean we can interpret that as we can, maybe only need a short period of hormone replacement therapy, or is this something that women should really just stay on? I mean, I've had doctors tell me that, it doesn't hurt to stay on HRT, for a longer period of time.
So the question is, what is the symptom that a woman is treating with the hormone therapy? And if it's vasomotor symptoms, hot flashes and night sweats, then we used to think that those symptoms went away after a couple of years after the final menstrual period. We now know that, in fact, for almost 30% of women, those symptoms continue for more than a decade after the final menstrual period. In response to this new epidemiological data, what societies have done, the Endocrine Society, the North American Menopause Society, the International Menopause Society have done, is they've all gotten together to have what's called a global consensus statement, which says that there is no stopping rule. This idea that a woman should use it for 5 years and stop really is not grounded in this new appreciation for how different women can transition through the menopause, and for some, the fact that these symptoms continue. Very important to have continued checkups when women are on the hormone therapy, but again, what one is treating is the symptoms, not the memory problems.
So if you're worried about cognition, though, I mean, there's a lot of different hormones on the market today. So just explain to us what the differences are. I mean, frankly, I was confused. I was told if you're worried about your cognition, 17-estradiol is the hormone that you want to be taking. But there's a lot out there. So how do we know? Obviously, we would not prescribe anything on being patient, but we would say go to your doctor and talk to your doctor. But just give us the basic ABCs of what the differences are in hormones that are available to women.
Right. So there's two general categories of hormone therapy. There's what we call estrogen alone therapy. Estrogen alone therapy is given to women who do not have a uterus. Women with the uterus need a form of progesterone. So if it's synthetic, we call it a progestin. They need a form of that to protect the uterine lining against cancer. And in fact, the addition of that progestin to the estrogen completely takes away the increased risk for that form of cancer. So that's why women need it. So hysterectomized women, estrogen alone, women with a uterus, estrogen plus progesterone. Then the next decision is what form of estrogen might women take. We hear a lot about bioidentical hormone therapy. The safest approach to getting what's called bioidentical hormone therapy, and by that what they mean is the form of estrogen that's most similar to that which our ovaries produce. That would be 17-beta estradiol. 17-beta estradiol is available in a patch. It's also available in a pill. So many practitioners recommend 17-beta estradiol because it is most similar to the estrogen that women produce. The second decision then for women with a uterus is what form of progesterone they might want to use. So a natural progesterone is called micronized progesterone, and many providers recommend micronized progesterone because it is like 17-beta estradiol in that it is most similar to what women naturally produce. There are, however, a variety of different synthetic progestins. Many women are exposed to these in the form of oral contraceptives or birth control pills, and those are also known to be safe options for women. From a cognitive perspective, there's actually data that both 17-beta estradiol and a synthetic form of estrogen called conjugated equine estrogen are safe for the brain in women in the early postmenopausal stage. I'd love to tell you that we have very good data on what form of estrogen women might want to take if they're highly symptomatic for their cognitive performance, but it's really unfortunate that we don't have a large randomized trial of hormone therapy in women with vasomotor symptoms. It's a real lack of information that would be important for women to have.
Okay, we're getting some more questions in right now. One is one viewer saying, I'm on a low dose of estrogen. I was once put on a low dose of testosterone. Doctors removed me from testosterone. There's Alzheimer's in my parental side of my family. So I guess the question is that should you not be, if you have a history of Alzheimer's, what do we do about testosterone? I mean, women have.
Thank you for that question. And really, what do we do about hormone therapy? There is not evidence to suggest that hormone therapy increases the risk of Alzheimer's disease or dementia anymore in women with a family history of Alzheimer's disease. That's probably because of this idea that the incidence of Alzheimer's disease is really age-related. So age is the largest risk factor for Alzheimer's disease, and much of the family history of Alzheimer's disease can be traced to longevity. So that's one issue. Testosterone is, it's been studied in relation to cognitive performance. There's some, I would say, inconsistent data to suggest that it could benefit visuospatial abilities, but there's not strong data to suggest a benefit for cognition. Some women use it for sexual reasons, so they want to increase their libido. In the United States, it's not used very widely, but I'll tell you, in Australia, it's used quite widely, and in Europe. It's just not a product that women in the States use, in large part because there isn't a widely available product for them to choose from.
Okay, another question that's come in is, I had, this year says I had a complete hysterectomy at age 48. Is it possible to go through physical menopause again at age 58? I have the same symptoms as I did at 48.
Oh, such an important question, and thank you for that question, because it brings up a very, very important consideration in this whole question about hormone therapy, and that's for the woman who transitions through menopause early due to surgery, so surgical removal of the ovaries. And there's very, very high quality data to suggest that those women really need to be on estrogen alone therapy, assuming that their uterus is removed, that they need to be on that estrogen alone therapy at least until the average age of menopause. And this data comes in large part from a study at the Mayo Clinic that shows that not only are women who have their ovaries removed at increased risk for Alzheimer's disease, but also for depressive disorders, cardiovascular disease, and early mortality. And so this is a group of women for whom the experts, meaning these leading medical societies, really say make sure that those women are treated. Now, for women who have had that experience, actually the data is quite consistent in suggesting, if you will, less negative effects of estrogen alone compared to estrogen plus progesterone. So providers are oftentimes, and of course this needs to be individualized and discussed with the provider, but they're often much more comfortable maintaining women on estrogen alone for many years after the final menstrual period. What she just described is the effects of withdrawing from estrogen. And in fact, many, many women will re-experience menopausal symptoms after they withdraw from estrogen.
Is it ever too late to start hormone replacement therapy? I mean, let's say some of our viewers out there might not have ever taken it and they're, menopausal, or, they've gone through menopause. Is it too late then?
So again, we want to consider the use of hormone therapy for symptoms. And there is data to suggest that women continue to have menopausal symptoms for more than a decade after the final menstrual period. However, it does appear from the best quality studies that hormone therapy, particularly combination estrogen plus progestin, is less safe the more years after the final menstrual period. So in women in their 60s and 70s in particular. What's interesting about that idea is that there's also very good data to suggest that it's the women who are showing objective cognitive difficulties in their 60s and 70s who actually respond the most negatively to hormone therapy. That's an hypothesis that Robbie Brinton calls the healthy cell bias, the idea that estrogen likes healthy cells, whether they be cardiac cells or neurons. And so we do not recommend that women initiate hormone therapy if they've transitioned through the menopause many years ago.
So we have another question that actually raises a good point too, which is, do hormonal fluctuations impact men? Like, do they experience cognitive decline due to hormonal fluctuations as they get older?
Yeah, that's a good question as well, and thank you for that question. So whereas women experience during the perimenopause dramatic fluctuations of estrogen followed by a plummeting of estrogen that remains plateaued and very low for the rest of their lives, men experience a much more gradual loss of testosterone, which begins in the late 50s and early 60s. And in men, there are rather large differences among men. Some men experience decreases in testosterone, others experience only subtle decreases in testosterone. There are some data by Scott Moffitt, actually, that showed that men who maintain higher levels of testosterone as they age actually have better brain functioning, brain structure, and a lower risk of Alzheimer's disease. The reason that that's of interest to us is that it actually is the case that testosterone is aromatized. It's converted to estrogen in people with high levels of testosterone. And so some of the data is very consistent with the idea that estrogen can be neuroprotective. However, I must say that the large clinical trials of testosterone and cognition have not panned out. So there is not a good signal there to suggest any benefit for men in using testosterone.
So what do we need? We've talked about hormone fluctuations in terms of, memory loss, cognitive decline during menopause, but what about in relation to Alzheimer's disease? I mean, a lot of our viewers have a loved one or are themselves impacted by dementia. So what do we know about the link between, maybe the drop in estrogen and brain disease, like Alzheimer's or other forms of dementia?
Yeah, thank you for that question. So the strongest data to suggest a link between menopause and risk of Alzheimer's disease probably comes from longitudinal studies that follow women who transition through menopause early. And those studies, for example, surgically induced menopause, those women who had menopause induced before the age of 50 had a 70% increased risk of cognitive impairment or Alzheimer's disease as they aged. The good news is that that increased risk was completely offset by the use of estrogen alone up until the age of 50. Now, recognize that although we would love to have the gold standard quality of data, that is a randomized trial, we don't have those data for women who transitioned early. So what I just mentioned was based on observational studies. Then there's a question about whether or not the fact that women transition through the menopause, it might be responsible, if you will, in part for the fact that 2/3 of Alzheimer's patients are female. Now, that increased frequency of Alzheimer's disease among women compared to men is really largely driven by women's longevity. So longevity, age, is the biggest risk factor for Alzheimer's disease, and women live longer than men. There is, however, some suggestion that estrogen might actually offset some of the pathology of Alzheimer's disease. That data comes from Kajal Kantarsi from the Mayo Clinic, who studied the role of 17-beta estradiol in a neuroimaging study, a small one, but an intriguing study that's now continuing thanks to the National Institute on Aging. Her study showed that women who were randomized to 17-beta estradiol compared to women who were randomized to placebo actually showed less Alzheimer's disease pathology on a brain imaging scan that actually measures that pathology in vivo. So that's intriguing, if you will, mechanistic supportive data. But really the only data that we have that looked at hormone therapy for the prevention of Alzheimer's disease actually showed an increased risk, a doubling of the risk of all-cause dementia, so that's Alzheimer's disease plus vascular dementia, in women who were randomized to receive this conjugated equine estrogen and medroxyprogesterone acetate, CEE-MPA, after age 65. The mean age of the women in that study was 72. So unfortunately, we don't have the primary prevention trials where the women are given the hormones earlier in life. The good news for women is that same study that showed perhaps an increased risk of dementia among older women who initiate hormone therapy showed that hormone therapy was safe for the women who were in their 50s. And so this idea that hormones are safer for younger women has been known as the critical window hypothesis, and so, or the timing hypothesis. And those data provide women with some reassurance that if they treat their vasomotor symptoms, their menopausal symptoms early, that it's safe, whereas delaying might be somewhat detrimental.
Right. So where does the research, I mean, it sounds like I'm encouraged by the fact that we're learning a lot more. It seems like there's a lot more research focused on gender and hormones in particular. But what do we need to know next?
Yeah, that's such an important question. And I like you, am so pleased to see that the government, through the National Institutes of Health, as well as the Alzheimer's Association, have specific calls for more research on sex differences in Alzheimer's disease, and we're learning so much. One of the key questions I think that's remaining is whether or not hormone therapy might confer cognitive benefits to women who have vasomotor symptoms. It's very interesting that there have been at least 3 very high quality randomized trials of hormone therapy and cognition, each in younger postmenopausal women, each showing that it's safe. However, we don't know what hormone therapy does to women who have moderate to severe hot flashes. And after all, that's the reason why women take hormone therapy, to treat their hot flashes. And there's good data to suggest that if women get better sleep, their cognitive performance is better, right? So if women are experiencing sleep disruptions because of hot flushes and you treat those, might there be at least an indirect benefit to women, not to mention a direct effect of the hormones on the brain systems that underlie good memory performance.
Absolutely. And we don't know what it's like not to have sleep,
It's true.
You don't have to really be going through menopause to have know that bad sleep equals bad memory, right?
Yes, that's for certain. That's for sure. Yeah.
All right. So sorry, did you have anything to add, Professor Maki?
No, just the final area that I, in collaboration with Rebecca Thurston, are exploring is this idea that the hot flashes themselves might contribute to memory problems. When women have hot flashes, there's a surge of stress hormones. And there's some evidence from our lab that shows that if those hot flashes are related to changes in brain structure, brain function, and memory performance. So we're investigating whether treating hot flashes might also confer a cognitive benefit to women.
Well, and we thank you so much for your research. It is very important, and I'm so glad that people are now starting to talk about women and hormones. There was a great op-ed in the New York Times just recently that dubs it "Mommy Puberty." We prepare our girls for puberty, yet when we reach our 40s and 50s, no one talks about it anymore. So I'm so glad that the topic is being discussed more, and in particular the research is focused on this because it is so important to the health and the brain health of women. So thank you so much for your research. We'd love to stay in touch, hear more as you discover and unfold more about how hormones are related to cognitive health and decline for that matter. So thank you so much, Dr. Maki, for your research and for joining us today.
Thank you. It's been a pleasure.